On this week, we'll go ahead and get started. I'd like to thank the staff and everything for the last 2 days. It's been great. Everything's been well organized, so thanks for everyone's hard work. I think we had a great meeting yesterday. I'd like to commend Gene and Todd and all those folks that made that happen. I think there's a great discussion. They work with excellent. The breakout session, the administrative group, and the level 3, level 4 meetings. We have to attend those. We did a lot of those meetings, and just a lot of work being done. So thanks for everyone's hard work. Looks like we have a quorum this morning. Thank you, Liz. We have on the line. Liz, we have on the line. Pete and Jim. Okay, so everyone is present. At this time, we'll get I need approval for the minutes. Can I get a motion and a second to approve the minutes from last week?
We do have a couple of addendums to the minutes.
No move.
For Michelle Williams. We could just add that she's Baker Donaldson appointed a special AG. She's not actually from the AG's office. And then just HIPAA from HIV PA to HIV AA, and then Dan Walsh, I think also needs to be added. They probably didn't QR code in since they just came to the presentation.
Okay, so those are new late minute additions to the minutes. So can I get a motion to approve the minutes?
No move.
Okay.
Sounds like Pete.
Who made a motion on that, Alan?
Jim had it.
And so Jim made a motion and then Vic second. All those in favor, aye.
Aye.
Opposed? Okay, so the minutes are approved. As far as my chairman's report, really no late breaking news for the chairman. Go ahead and move right into that. So Liz, executive director's report.
Yeah, I'm going to keep my remarks brief too, so we can spend our time with Dr. Prock because we've been eagerly awaiting the presentation. Just a few quick updates. We have already presented on the House side for our FY24 budget, still awaiting to present on the Senate side, but that is moving through its process. As mentioned a few times yesterday, the ACS trauma system consultative visit and rural focus review final report should be available early April, and we will certainly push out to this group as well as post to our website, so stay tuned for that. And then that's it on the major updates. Everything is in my report though, in your packet. And for those of you, our packet's always online. And we post that about 2 weeks in advance. I believe this might be in your packet or as a separate tab line, but you all have this like little card. I just updated our strategic plan a little bit because some things have changed. I'm not gonna go over this in any great detail, just review it and the commissioners could let me know. It's more of just an update of where we are. And as I mentioned before, the strategic plans, the guidelines of those are set forth by the Governor's Office of Planning and Budget. So it's not very templated and it's really an inward agency for the strategic plan, not necessarily related to what we do with the trauma system, but sort of how we operationalize all of this. So that's sort of how we set our goals. And
Liz, can I ask a quick question?
Oh, sure.
We spent a lot of time and effort on going through the trauma system complicated. And so once the final report, we've already got the preliminary report out from them, so we kind of know what the report's going to say. What's our next steps with that as a committee?
As if I teed you up for that question, but I didn't. Mr. Chairman, I'll defer to you.
Well, we are working closely with our partners at OMST, Xavier Crockett, director, and Sarah Rubin back there. We'll hear more from them today. But we've already started. We had what we're calling now sort of the executive committee made up of leadership commission, which is Liz and myself, and they're we're starting to gently dive into some of those issues.
Okay.
And we've already made some great progress, I think, on some ways to address some of the issues. We're not quite ready to handle that. We don't have it ready to really brand new commission yet, but we're starting to work on that. And that's just the start. Really been productive. Our first one had one meeting, but it was very productive. And what I think will come from that will be come to the commission. We'll need forms, work groups here. There will be a decrease in things that probably get divvied up. We think there is a level 3, level 4 committee. There will be decreasing things divvied up probably to the administrators group, and then maybe even that ultimately commission some volunteers to dive into some of those. So there'll be we'll have to have an organization meeting on what we want to attack, because there'll probably be the last report. Years ago we got 110 or 112 recommendations. So as a commission, we'll have to decide, what our short-term goals or long-term goals. So that's sort of a long-winded question or answer to your question, but we'll need to organize it a little better.
Yeah, thank you, Dennis. I just wanted to make sure that this doesn't fade off into the distance, that we continue to press forward. I'll be happy, obviously, to be involved in anything that will move going forward, but I'm just glad that I knew there was a plan. I just wasn't completely understood what the plan was. So I'm glad to hear that we're going to take these recommendations seriously and we're going to move forward and try to use their recommendations to make these decisions.
Right.
Thank you, sir.
And thanks for volunteering. I promise I'll give you over 30. Okay, good question. Any other questions?
I think so, yeah. Just on the strategic plan, the only thing that, Katie and Gavin, first of all, the entire team, and as you already mentioned, the planning and preparation around this meeting has just been amazing, and with Cheryl's partnership and the feedback that I've gotten so far is that this is really very beneficial, and the group gets a lot out of meeting in person. So thank you guys for all the work you do to get this to happen, because they do a lot behind the scenes that we don't see. One of the things that we have tried really hard, and Gabby has almost exhausted every software mechanism out there, is to try to automate a lot of our processes around invoice tracking. We try to be very mindful. And all of you, the trauma centers, the TPMs who submit your invoices, the EMS equipment grants, will let you know where your payments are in the process. We communicate with you, we've received it, we've approved it, your payment has been processed, your payment has been released, your check has been sent, and there is no way to automate that. And unfortunately, that is, particularly with the EMS equipment grants, it is a lot of work. There is just no easy way around the fact that it's a huge manual process. So we had it on the strategic plan to sort of automate it, but it's not possible. So it is, I just, for situational awareness, it's a huge man-hour sort of effort to track, but it helps us because then we know what payments have been processed, and we're almost, we're at the point now where if you haven't submitted an invoice and we owe you money, we're coming after you to get you your money. So that's how we get every penny. Besides, how much was it? $841 out of $22 million that was sent back. That's how we can accomplish that.
Okay, very good. We'll move into our really what I would call one of the keynote presentations this morning with Dr. Anthony Sprack. He's a professor of economics from the University of South Florida. Really no stranger to this group, although it's been a while since he's been here to present, so some of the new members may not be aware of his work. If you go back maybe 7 or 8 years, Dr. Sprack, you may wonder why somebody from Florida would be here in Georgia go over our trauma system, but he has a tremendous amount of experience analyzing the Florida trauma system and has published a large number of papers for their trauma group in there. That's how we sort of got on our radar screen. And if you remember back several years ago, we did an analysis of the state. What is our access? The trauma centers make a difference. What's the probability of survival in the trauma center versus the non-trauma center in Georgia? We had national data. That is very good, but for our legislators, we needed Georgia data. He helped us analyze all that data, which is very, very use some methods to analyze their data. And that was very fruitful. It really gave us a foothold to know where we were. We showed that trauma centers do make a difference. There's a 10% increase in survival in trauma centers in Georgia for critically injured patients versus non-trauma centers. So that we showed that we got a good return on investment for our legislators. We then looked at access and noted that we weren't doing that great. Only about 65% of patients that were critically injured were being treated at designated trauma centers in Georgia due to efforts of all of those in this room through the funding and hard work, again, all the stakeholders in the room. We were able to show through this analysis that that number steadily increased over the next few years from when we started the analysis to from 65% to 85% for all groups. You look at the pediatric groups, look at Dr. Bridger there, representative surgeon, that's peaking out about, I think, if I remember the table right, about 98%. So it's been a minute since we analyzed the state, so we asked him to come back for a sequel and another analysis and see where we stand today and what we need to do, which is in good timing with what Dr. Dunn was talking about our ACS. We now have two big analyses, if you will, to go over and work on the next 5 to 6 years of where we want to go. So Dr. Brack, welcome back to yours.
Thank you, everybody, and especially thank you, Dr. Ashley, and also Liz for working with me as I get this report. I have a tendency to have way too much detail. Help me focus this thing. Spare you guys. When I went through this, it took me about 45 minutes, so we should have some time for questions. So please just stop at any time.
Anthony, could you get just a little closer to the mic? It's a big room, and I want everybody to hear you.
Ready? All right, so as Dr. Ashley indicated, this is our third go around, about 10 years before we started. Looking at this. At that time, there was the question of new trauma systems that should be had. And some of you probably wondering why do we have to ask that question. At that time, about half the studies that have been done actually showed the opposite. And the other half showed this. What we went through, some of them were done very poorly, so no surprise there. And some of them used data systems that were very immature, very young. And that chance to mature yet. So when we started, that's the first question we asked. And unfortunately, she probably had 3 years to actually explain that it has tremendous value to systems. Now, the follow-ups, since we're not asking that question anymore, now we are more occupied with making sure that the residents of the state, the United States, have access to services. This report focuses on advancing. So this report focuses on the objective is to make sure that Georgia residents have adequate access to the trauma service, and where our focus is on the inpatient side. I'm going to go through the Georgia system very quickly. I think all of you are very familiar with it. You've seen the map that you've seen many times already. One of the more important things that we need to look at, of course, is proximity of residents to trauma centers to residents. Then we'll look at the data itself. A little bit about it over here. It made sense to me. Hopefully, it makes sense to you to do it that way. We'll talk about the rate of trauma alerts. We're going to look at 2 groups of patients that are classified as trauma alerts. and patients were not classified as trauma wards, but were nonetheless at risk and classified as emergent. We'll look at the demographic characteristics of these patients, their injury types, and then there's a regional analysis as well that we'll go through. This map, I'm sure all of you have seen before. It shows the configuration of the inpatient trauma system at the end of 2022. I understand at least 3 more hospitals over the years, of course, been added in region 4. Those are not shown on this map. But we'll get to each of the regions entirely at the end of this presentation. So proximity to a trauma center population. We're going to look at 2 variables: travel distance, so ground transportation times, so travel distance and travel time. The data for this was obtained using Google Maps. That means that there's going to be some variation that depends on things like the time of day and traffic conditions. That will give us some indication of what it looks like. This slide has 2 sides of it. On the right-hand side, it looks a little busy with the charts. The 2 important points are on the left-hand side, driving distance and driving time. So about 83% of the Georgia population lives within 50 miles of level 1 or 2 center. If you add the level 3s and 4s, that goes to 96%. And again, this is the configuration at the end of 2022. That probably has gone on. When you look at driving time, about 94% of the population lives within 1 hour driving, probably level 1 or 2. If you add the level 4 or 3s and 4s, that goes up to 99%. So there's very little room left for improvement as far as driving times in those centers. The charts on the right, again, are very busy, where they show the progression as you increase how much of the population lives within 10 miles, 20 miles, 30 miles, and so forth. And you get to that 83%, 92%, 83%, excuse me, when you get to 50 miles. These maps, I think, are easier to look at than data on the previous slide. There are 4 or 5 categories as we're looking at driving distances here. So we have 4 groups, 25 miles, 25 to 50, 50 to 100 miles, and over 100 miles. And as you read from left to right, looking at the maps, the one on the left shows you the distances for the areas in Georgia covered by level 1s and 2s. And then if you add level 3s, and if you add level 4s, so to the right. This was done using the census block level. So like an average driving distances, that's the smallest group that you can get to using the census data. Now, as you can see, looking at the one on the left, there's still quite a bit in the south of Georgia that is quite a distance from the level 1 or 2. In area 8, which is in the southwest corner of Georgia, that used to be level 2, now that's what converted to level 3. That's what happens like that. So if you look at the map in the middle, that's where we add the level 3s to the equation. As you can see, that area shrinks quite a bit. So now you're left with an area in the southeast of Georgia, where you still are at least 100 miles away from the nearest center. Then if you add the level 4s, that's the map all the way to the right, you're left with just the triangle. Moving from driving distance to driving time, okay, again, reading from left to right, and we have 4 groups. Now we have under 30 minutes driving, 30 to 60 minutes driving, 60 minutes to an hour, and over an hour actually over 2 hours driving. And as you can see, again, no surprise here, it looks very similar to driving distance. In the south of Georgia, you have that large, that dark purple area where the driving time to the nearest level 1 or 2 is over 2 hours. At the level 3, that's the map in the middle, and you're left with just a little bit still on the southeast part of Georgia, and when you add the level 4s, pretty much everything is covered. Any questions at this point? Now, Georgia is not an island. You are surrounded by other states. Some of you might want it to be an island. We are surrounded by other states that have their own trauma systems. This map shows the level 1s and 2s in surrounding states. Each green dot is either level 1 or 2, and around that green dot you see a 50-mile buffer that shows you what part of Georgia falls within maybe their service area. I'm not sure what kind of arrangements you have with hospitals outside of Georgia, but that's certainly something we consider moving forward. Understand your system. In Florida, for example, in 2020, 733 Georgia residents were classified as trauma alerts in Florida hospitals. Of those, about 40% have been transferred there from another hospital. We don't know which hospital or whether they were from a Georgia hospital, just know that they were transferred from one hospital to the trauma center. Yeah, we're this computer has a mind of its own. It's artificial intelligence. Yeah, absolutely. All right, so now to the data. The data that we used for the inpatient part of this analysis came from the Georgia Department of Public Health, and it's going to cover up to 2020. We have data going back all the way to 2003, but we're going to focus on the last 5 years for reasons that are going there in just a little bit. This data gives us it's the unit of analysis is the patient, this data. It gives us all the diagnoses, which we can then use to figure out whether patients were at risk or not. It also tells us whether a patient starting in the later years, it will indicate whether a patient is classified as a trauma alert or not. In the earlier years, we kind of had to make an educated guess as to whether patients were true trauma alerts. It also gives us the demographics, so we can analyze patient population in that sense. Also tells us something about their insurance status. For the data we used earlier, we used the US Census in 2020, and we used, obviously, Google Maps for the distance and time. So, again, we are going to divide our population, the patient population, into 2 large groups, those who are classified as trauma alerts, and those who are classified as emergent, but they were not classified as trauma alerts. And we just jump to this slide. What we want to focus on are those columns in the middle. It looks a lot better on the screen right here. Focus on the 2 columns in the middle that are in bold, and that's supposed to be blue. The color is not coming out very well. For this analysis, an at-risk patient is defined as one who has what's called an ICUS score of less than 0.85. ICUS scores are calculated from survival risk ratios, to tell you what percentage of patients with a certain diagnosis survive. So you can think of an ICUS score as a probability. An ICUS score of less than 0.85, you can think of as indicating that the patient had at least a 15% probability of not surviving the combination of disease. So that's what we call an at-risk patient. And so focusing on those 2 columns that are in bold, you can see from 2016 to 2020, there were, that combined, there were 7,159 patients who were classified as trauma alerts and who were at risk. If you look at all trauma alerts, not just the ones that are at risk, that matters, right? You still have to go through all the logistics, they still have to be treated. And actually, we can argue, 50% might be a high bar, and if you have 10% probability of mortality, that's still high. So it's still, even though we classify it this way, still very important to look at. That's the column all the way to the left next to the years, and it shows us that there are almost 90,000 of those in those 5 years. Then that second column that's in bold, that shows us the patients that were classified as emergencies, not trauma alerts, and still at risk. And so for those 5 years we looked at, there were over 12,000. If you look at all of them, there will be the third column. There were 336 patients, 36,000 patients in those 5 years that were classified as emergencies. And needed immediate care as well. And if you go to the center part of this table, that's where we're looking at patients who are treated at level 1 and 2s. And what we're interested in is that center column. As you can see, those patients that were trauma alerts, which you would expect all of them should be seen at a trauma center, which they were, but leaving out the level 3s and 4s, as you can see, about 95% on average of those patients were treated at level 1s and 2s. For the emergency patients, the column next to it, that's about 80-something%. You would obviously expect it to be. Then at the bottom, that's where we have the level 3s and 4s. And there's a little bit of hiccup there in 2018. I'm sure all of you focused in on that. But hey, there's some trauma. How can that fall below 100%? There were a couple of patients who were seen at non-trauma centers who were nonetheless classified as trauma alerts. It was probably an error, and that's what's important. And they still exist. For the emergency cases, when you add the level 3s and 4s, we're still around 85, 86% treated at trauma centers. Cool.
Yeah. Dr. Brock, I had a question.
Oh, sorry.
Are these percentages final destinations, or are they that they've reached a level 4 and then subsequently level 1?
That's the final destination.
Okay.
The data does tell us how many patients came in as transfers from another facility. Its full covers around 1%. The reason why we're focusing our report on just the last 5 years, in 2015, there was a transition. All of you went through this when we went from ICD-9 to ICD-10. When we looked at this data, other things changed. I'm sure hospitals have to update their systems, and so how patients are classified may have changed. But when you look at the patient population that we are interested in the most, and that's the column in the middle that is highlighted in bold, you can see that there's a nice transition. There are no big hiccups, as the trend line looks good. In other words, we don't have to worry too much about the data having gone haywire because we have changed when I say that. Which means that in the other slides that we're looking at later, you can look at some longer trends as well when it comes to access to electronic systems, the trauma hospitals. Here are the demographic characteristics. The top half of the table shows us all patients, all severity levels, and the bottom half shows us the patients that were at risk. Focusing on the patients who were at risk, you can see most of them were non-elderly adults. So about almost 60% non-elderly adults. The elderly make up around 40%, and children, very small percentage of the at-risk group. Looking at the gender distribution, most of them were male, 69%. Trauma was a male disease, classified that way. and most of them were white, about 60%. And in the emergency cases of all of this, in focusing on the group that is at risk, so that's the bottom part of this table, the distribution doesn't change much. Most of them are still not elderly adults, less than 60%. A few more kids, yeah, that's up to about 2.6% now. Looking at the gender distribution, again, most of them male, 67%, and still a little bit more than half white, looking at the racial distribution. Insurance type, this is important for your finance people. The most important contributor as far as payers, is my contributor, most important payer when it comes to trauma. On the top half of this table, we're looking at trauma alerts, and the bottom half, we're looking at trauma alerts and emergencies. And this includes everybody, not just the at-risk population. So Medicare was the largest payer with, in 2020, 32% of all patients. Followed by the commercial group, close to 20%. And then we have the uninsured, which in 2020 jumped. We'll noticeably right there. We're not sure why, but that's something to do with this pandemic that all of us are trying to forget. Okay. There was another group called Other, and when we try to dig into it, it turns out there was no detail in there. They're just classified as Other or Unknown. But they make up quite a large group as well. When you look and you add the emergency cases, Medicare increases, they now are up to about 45% in 2020. Commercial drops, which is probably not what you want to see. That's where more of the dollars will come from. And the uninsured, that's also drops a little bit when you add the emergency cases. Questions? Type of injury. Then we have two groups. Then we have well, 3 columns here. On the left, we're looking at trauma alerts. In the middle, we're looking at the emergency cases, and then we combine the two and everything on the right. And the columns that are in blue are the ones that are referred to the population that we're most interested in. Those are the at-risk patients. As you can see, traumatic brain injury, very important. The 46.9% of the trauma alert patients had traumatic brain injury. Skull and spinal cord injuries, SSCI, those are that excludes patients classified as having TBI, so no one overlap in this table. And as far as that group is concerned, 57% had SSCI. And fractures, 25%. Again, that does not include patients with TBI or skull spinal cord injuries. Then we have injuries to the thorax, 56%. Vascular injuries, 10%. The other injuries those are injuries that are non-life-threatening. As you might expect, obviously, the at-risk group will have more serious, severe type of serious injuries. When we look at emergencies, all those categories are still important. 38% with TBI, 47% with skull spinal cord injuries, fractures 21%, injuries to the thorax 48%. The group with non-life-threatening injuries there does go up almost to 10%. Length of stay for trauma alerts, on average, is 12.3 days with a standard deviation of 17. It goes down slightly when you look at emergency patients. That's at 11.4%. Didn't go down by that much, still very high. When we look at the mortality rate for trauma alerts who are severely injured at risk, the mortality rate of about 69%, which goes with the definition of the highest score. And I would say at least 50%. So we have 16.1% right there. For the emergency patients who are at risk, we have a mortality rate of about 7%. Much lower than the trauma alerts, which you would expect. And then when you include the combined, you're going to get something in the middle on the right.
Hey, could you just make a comment for the audience on the difference between, I just want to make sure everybody understands the difference between trauma alerts and emergencies. Just to clarify that.
Okay, so the trauma alert, whether the call, whether a patient is going to be trauma alert, is made usually in the field by the EMS workers. There are a lot of unobservables involved. But something told them, they're looking at the patient, whether it's the amount of blood or the position the patient is finding, or the accident they were in, and then be elevated to a higher level of severity. The patient needed more immediate care with all the specialists that they require present. So the distinction is a little difficult to make. As I said, it's going to depend on, it's made in the field, and I believe also that in some cases, when the patient is brought into the hospital, somebody on the medical staff looks at this and says, hey, this is more serious than we thought. We have to elevate this and get the trauma, which explains that higher level of mortality. Does that help? Any other questions? I'm not sure exactly how the calls are made and who has the authority to make the calls. I assume that any medical staff that listens to something and say, hey, something is not right.
And just a clarification, Dan, emergencies are injured patients that are not elevated to the level of trauma. They're not heart attacks, they're not strokes.
Right, so they're dealt in with the emergency room and normal by the emergency office without alerting, without activating the trauma team in the hospital.
Do they have an ICA score or ISIS score of less than 0.85?
They can
critically, we're just dealing with critically.
Right, they can have exactly the same injuries as shown by the ICD-10 classification. Right? But there was something else, okay, that is not in this data, okay, that intuition told somebody on the medical teams, hey, this is serious. This needs to be elevated. Dealing with those unobservables, by the way, is why earlier when I mentioned that there were a lot of studies that showed exactly the opposite. Right? That trauma systems actually had higher mortality rates. It's because they were not able to incorporate in the analysis these unobservable things that are obviously not recorded because they're unobservable. Just intuition. So they were observed, but they were not recorded. All right, where were we? All right, so the thing that we're interested in the most, obviously, and the objective was to look at access to inpatient services. So again, we're focusing on that center column that's in highlight in bold and blue. And the one that we want to focus in on particularly is all the way to the right, versus total. And as you can see, for the at-risk group of patients from 2016 to 2020, the percentage for triage to trauma hospitals went from 83% down to 90, 92, 92, 93.
Recording in progress.
Which is what we want to see, the percentage going up. Here's a longer trend. When we started, Dr. Ashley mentioned where we were a long time ago, around 60-something%. It's a nice progression as the system has matured. We've reached now 93%. We want it to be 100%, ideally, yes. That's an economist who will tell you, well, maybe 100%, ideally you might want it, but the problem, of course, is there are trade-offs, there are costs. So 100% might not be attained. But maybe strike, good goal.
I don't want to slide out everyone's attention. This is why we're all here. I mean, this is amazing. You can see that when we started, we were about 66%. Years ago, we did the first analysis, and we worked hard. Everybody in this room, this is something everybody can take credit for. Should be proud of. It went to 85% on the last analysis, and now we're up over. Can't see the number. 90.
Over 90.
98% for critically injured patients, not all patients, but critically injured patients that have a chance of 15% of dying or making it to designated trauma center. So this is, we've made tremendous progress. So this is a moment with all of our work that everyone should pause and say, we did a good job. So I just don't want that to slide by. People are hard here, and everybody here is volunteers. Volunteering your time now. This is something that we should be proud of.
Right, and don't forget that's a valuable advantage. Now, beginning, when Dr. Ashley introduced everything, he mentioned something about 10%. That's the lower bound. It's probably much higher than that. That's a valuable advantage. We could only uncover the lower bound because of statistical techniques and the difficulties in that regard that we have to do. But it's probably, looking at other studies that have more data, it probably hovers closer to 20%. This is the same data, but selected years. Again, the progression. Selected years here were 2003, 2010, 2016, and 2020. Then, if you look at the breakdown by age groups, on the left, you've got the pediatric patients. In Georgia, almost 100% of pediatric severely injured or at-risk pediatric patients are treated at a trauma center. Kudos, that's good. About 99% actually. If you look at non-elderly adults, those are the one in the middle. You can see that a nice progression, getting to 97% non-elderly adults. For the elderly, that's the one on the right. You can see an increase, very steady, significant increase, maxing out at 87%. So there, that indicates that there is some more work to be done, or be a little closer at that special population, at this population. Is that the right percentage? Are they making it to the right place at the right time? This is the same data as before, but just the numbers, so I'm going to skip it. This very busy map shows three groups. Okay. The dots in blue represent trauma alert patients. So each dot represents 10 patients. The blue dots are patients who are classified as trauma alerts and were treated at a trauma center. So that's nothing further to discuss there. Then there are the green dots, okay, which are emergency patients who were not classified as trauma alerts, but they were nonetheless at risk given their severity scores, and they were treated at trauma centers. So that's also a good thing. And then there are red dots. You might have to work very hard to find them. The red dots are patients who were classified, were at risk, but they were treated at a non-trauma center. And if you look at it, most of them are scattered around somewhere in the south. There are very few of them on top where most of the trauma centers. So the areas where some thought needs to go into would be and that brings us to the EMS regions. I'm going to have a few tables on each one. We're going to go through this very quickly. There's quite a few. So, region 1 in the top left corner. Those are the counties in the region, the population. Region 1 had 1 level 2, 3 level 3s, and a level 4. This table shows us transportation distances and times. Okay. On the time side, to the right, highlighted the counties that have travel times of more than an hour to level 1 and level 2 centers. So the average or the mean travel time to a level 1 or 2 in region 1 was 42 minutes. The median was 36. And then the last column shows you what happens when you have a level 2 force. The column on each one of these, for each EMS region, the column of interest is the fourth one, counting the county name, which tells you the percentage in that county that made it, that were triaged to a trauma center. So, but it's a column labeled percent treated at a center. As you can see, most of them, despite the travel times, most of them are in the 90% dollars. 90% or over get treated or triaged at level 1, as you said. Here's the trend for EMS region 1, very nice. It went up, and it's in the last few years, the percentage triage to the trauma center at-risk patients is about 9%. So EMS region 1 is doing well. EMS region 2 has one level 2 center. There are counties for animal populations. There are 3 counties in that region where travel times are over an hour, level 1 or 2. The mean travel time is 36 minutes. The median is 30 in that region. Again, focusing on that fourth column, you see most counties do very well. There are a couple counties in the 60% range, 67% range, but most of them are in the 90% range. I'm looking at the county overall. There's the trend line. A little bit of downside in the end, but we're still in the 80 and 90% of the triage from those concepts. I just accidentally moved to adjust that. And the MS3, that's where most of your population resides. 2 level 1s, 4 level 2s, and there's 2 pediatric centers as well. There are no counties in that region where travel time is more than an hour. Let's get through that. No surprise. Okay. The typical percentage of patients, at-risk patients treated at a trauma center is over 9%. And this is what the time frame looks like. Okay. In the last 4 years, between 90 and 100%. Region 4, there are the counties. I did not include the new centers that were just designated this year. There are 2 counties in Region 4, despite them not having a level 1 or 2, only 2 counties where travel times are over 60 minutes. What would have changed in this table had I included the new centers within that last column. I should have proceeded there, so probably not either. If you look at, however, the patient, the percentage of the patients, the at-risk patients from that region that do make it, are triaged to a trauma center, there doesn't seem to be a problem. Most of the population in EMS region 4 lives adjacent to EMS region 3 and say they have access to those services. This is what the time trend looks like. Again, despite not having level 1 or 2 center, you can see in the final years the percentage of patients, at-risk patients, that are treated at level 1 or 2 is over 9%. EMS region 5, lots of counties, I just squished it all in there. Has one level 1, level 3, and level 4. There are, let's see, 1, 2, 3, 4, 5, 6, 7, 8 counties where travel time to a level 1 or 2 is 60 minutes in region 5. When you include the 3s and 4s, everybody was within 60 minutes. And if you look at the percentage treated at a trauma center of severely acute patients, it's pretty good. And there's a trend line. If you look at the last 4 years, 99%. Region 6, on the east side, there are 3 counties with travel times over 60 minutes on Google Maps. And if you look at the percentage of those at-risk patients triaged to a trauma center, again, quite high. If you look at the trend line, actually gets pretty close to that. Region 6, Region 7 has 1 level 2, 4 counties with average travel times over 60 minutes, level 1 or 2. Some variation as to what percentage is triaged through a trauma center. And these are at-risk patients where they get triaged to. Here's the trend line. So the last 3 years, always between 80 and 90%. Region 8, and that's a big one down south, lots of counties with 1 level 3. Lots of counties with travel distances over 60 minutes. No surprise there. Actually, there's only 1 county that a travel county less than 60 minutes. Level 1 or 2. And obviously, if you look at the percentage, the 4th column of the at-risk patient population, and it's triage to level 1 or 2. There's going to be quite a bit of fluctuation. This is what it looks like. It's somewhere in the final 2 years, somewhere between 60 and 70%. So that's the county where you're going to find the largest percentage of at-risk patients not triaged to the trauma center. Region 9, another big one, has a level 1 and a level 4. Still also quite a few counties with average travel times over 60 minutes. But I'm sure you're familiar with that area. It's small. Very few people might be living in there. If you look at the percentages, still you see some variation, but if you look at the trend line overall, even as Region 9 actually does pretty well in getting its patients to trauma centers. Then that brings us to the last region, Region 10. It has a level 2, a level 3, and a level 4. There are no counties in that region with travel times over 60 minutes, to level 1 or 2. If you look at the percentages, very high. So just look at the trend line, we get actually pretty close to 100%. A quick summary of regions. So this is the percentage of at-risk patients treated at a trauma center by year and region. Each row shows you the EMS region, and then you have columns. So for example, in 2020, let's just go to the last year. In each of those columns, the red shading or pink shading indicates the highest percentage. So EMS region 5, that's what Dr. Ashley is. Comes up, 97%. And of course, region 8 with on the lowest at 65%. The second column shows you the number of at-risk patients, and no surprise there, region 3 with the highest. The demographic characteristics, it shows you which counties have the highest percentage of males, females, or lowest percentage. Perhaps the most interesting part of this table would be the uninsured. So region 7 has the highest percentage of uninsured patients. Region 4 has the lowest percentage. Injury type by region. So again, red shading means the highest percentage, green shading is the lowest. TBI is the thing that most people are worried about the most. Region 5 has the highest percentage of patients with TBI at 47%. When it comes to skull and spinal cord injuries, also region 5. Fractures, region 4. Injuries to the thorax, region 8 has the highest percentage. The vascular injuries tend to make up the lowest percentage of the region 3 comes in. And then that last column, which shows you the percentage of patients that did not survive, region 7 had the highest percentage. Region 10 had the lowest percentage of patients that did not survive. Population density. The interesting thing here is that almost 40% of the population of the state lives in EMS region 3. And if you just go to the right, the population per square mile is 1,793 people per square mile in the EMS region 3. With region 8, and this is important because in region 8 we kind of identified as an area where it might need more centers, but that's also the area where you have the lowest population density. So there are lots of questions that are going to have to be answered. A few more analyses. What do we do? On accounting rankings, that first column shows you the average number of at-risk patients for 100,000 population. So now you have a denominator that's a little different. The number in parentheses behind the county name, that is the MS region. So Warren County in region 6 had the highest annual average number of at-risk patients for a 100,000 population. But as far as the actual absolute number is concerned, that's the second column. That's where you can start seeing the counties in region 3, where most people live. The third column shows you the percent of at-risk patients who are treated at the center. That there obviously the counties are 100% came in there, so that's very little information in there. But then the last, column shows you the population per square mile. That's where we see all the EMS region 3 counties. And that brings us to the final section. The volume of at-risk patients and where they were treated, trauma center or non-trauma center. So for each region, I'm going to show you the top trauma centers as far as the volume is concerned of at-risk patients, and the top 2 non-trauma centers and their volume of at-risk patients. This might come into play in decision making as far as designating other hospitals. Now, a quick disclaimer, the Department of Public Health stopped identifying hospitals with a new policy back in 2017. They did give me a number, that's the number you see on the left, and I did have a whole list of names going with the numbers. I looked them up by coordinates and whatnot and verified, but I cannot vouch 100%. I got the names right of the non-trauma centers. And so in EMS region 1, the non-trauma centers are the highest volume of at-risk patients in those 5 years. There was Northside Hospital in Cherokee County, 35. In EMS region 2, it was Northside Hospital in Forsyth, 109 patients. And EMS region 3, the trauma centers are the ones in bold and blue. So if you just move down to the first black line, that shows you the non-trauma center with the highest volume. And EMS region 3, that was Cartersville. Put an asterisk there because I found 2 Cartersville medical centers in different regions. Just a little. In EMS Region 4, that's an interesting one. The non-trauma centers with the highest volume of at-risk patients are not the ones that were just tested. Piedmont, I think Wellstar hospitals are the ones that were estimated as trauma and police reports. So Piedmont Fayetteville Hospital is the one with the highest volume. In Region 5, the hospital non-trauma center with the largest volume was Houston Medical Center, which actually has a higher volume than the other level 3 in that region. In Region 6, it was Select Specialty Hospital with 79. In Region 7, the non-trauma center with the highest volume was St. Francis Hospital with 90. Then in Region 8, that's the interesting one. The non-trauma center with the highest volume was Phoebe Putney, which actually had more than the hospital that is now a level 3 that used to be a level 2. In EMS Region 9, Southeast Georgia with 100 patients, and in EMS Region 10, St. Mary's with 48. The interesting thing is that none of the level 4 hospitals actually made it to this list. And that was the last slide. So we have time. How much time do we have for questions?
So, Aiken, that was great. Just a lot of data, and almost too much to take in one setting. I've seen a lot of this data before, and still, every time you see it, you see something new. So we'll need a lot of time to go over this. Everyone can have this data and look at it and bring questions forward. But if somebody has a question.
Yeah, and my email address, I believe, is on there somewhere. So you feel free to email me with any questions.
Thank you so much for the data, for sharing the information, My question is regarding the burn data. I didn't I didn't see any data for burn.
That's at the end of the report. No, we did not include the burn data in this. There are a few. And at the end of the report, there is an appendix that shows the burn.
And where you show where the injury type of injury, and we just tell them, I'm from a burn center, so that's why I'm asking, because I'm looking for the data spot. Is it considered an other category?
No, you got to be completely separate.
Okay.
Yeah, there's, I was privy to listening to that debate in Florida whether we should approve burn victims or not. And that's when they included us, and that's a completely separate population. They go to different places, and so let's keep them separate. And so I kind of made the decision to do that as well.
Hey, Tim, quick question for you. Looking back at the types of injuries, and when you separated out the TBI, vascular, torso, the number that really stood out to me was the SSCI category. I mean, that was the highest population by far in all categories. And, when I saw that category, it's like, well, that's spinal cord, but it's also skull and spinal cord injury, right? So is it also lacerations to the faces? Is that our elderly population who falls and doesn't have a TBI, but has a laceration? Are they in that category? Or is it just skull fractures and spinal cord injuries? And is spinal cord injuries people who are paralyzed? Or is it a transverse process fracture of the spinal cord or the C-spine?
It's all from the ICD-10 codes. So
okay.
Laceration is probably going to be the vascular injury.
Okay.
Right. It's the skull and spinal cord injury group. If I remember correctly, if you look at when we're actually listing them, we're using ICD-9 codes, we actually listed them, not go over 5 pages. That tended to be the largest.
Sure.
Actually, I'm sorry, fractures was proved, but once you take out the skull and spinal cord injuries, that's.
Yeah, I guess this, in my patient population, in my job, I don't see the vast majority of skull fractures and spinal cord injuries as the people that I treat. You know, I guess I just don't understand that category very well. And we need to maybe dive into that a little bit.
Right, so the injury that caused the patient to be classified as a trauma alert might be a different one. It just means that they also had one of those things. Right. So it's very possible that they had a skull spinal cord injury that had a spinal cord injury that was very high. So you might not see it. And so they also treated.
But you mentioned that TBI was taken out of the SSCI category.
Right, so I didn't want to overlap.
Sure, right, yeah. So it's just fascinating. I guess we'll have to think about that.
Right, so the injury that triggered the trauma alert was probably very likely one that was associated with the guy.
Do we have any idea why the elderly have a significantly lower percentage going to a trauma center?
We looked at that in Florida using the mechanism of injury codes. We have more complete data over there. A lot of them, even though the injury itself, using an ICD-9 or ICD-10 code, was the same as somebody who was more severely injured, that was a result of, in a lot of cases, a low fall. They trip over a rug or something like that. So there were low impact or low energy transfer kind of injuries. The argument was that a lot of those patients, elderly, were not true trauma alerts, were injuries to low impact. The problem with the elderly, of course, is that injury doesn't look like much and very easily escalate into something worse. And it's a very difficult population. So when you go out and say, we need just 100% of them to go trauma centers. If you do that, you're going to run into a lot of cases that were not true trauma alerts. You might start getting into trouble and who has to pay. So it's a tug of war. What do you do with that population?
I think we have had some movement because you and I talked about this before, just in the go back and forth, but we still, because the data set, what was the last year of the data?
2020.
Yeah, 2020, and particularly for Region 9, we still have the level 4 that was in Baxley on this, and they voluntarily left the system. So because we, I think it shows like that overall access is probably better than it actually is now with the departure of that one. In addition, at the same time, we lost a level 3 in our Southview, which I think is in Region 5. Alien Hospital system. I think was that Region 5 where they were doing the fix. Anybody know Region 2? And then with the addition, so I guess the question is, and then also of course we lost the other level 1 in Atlanta, but we know that Region 3 overall has good access. So how do we, like, we don't want to wait another 10 years to find out what those impacts are. How do we, is there some way to fancy terminology, to do almost like a predictive thing with removing those centers, because I'm worried that like we're showing access is maybe better than it actually is with the departure of some of those centers that cover those vulnerable areas. Does that make sense? Or
predict which centers,
or how the access would have changed if you took those out of it. And maybe we can't, maybe we just need to have like a 5-year subsequent analysis as opposed to, waiting the whole.
Well, what region was the new ACS verified level 1 in?
2.
Is Region 2, it's not close to Region 3?
It is, but Region 3 isn't the problem because the overall access, remember, we're talking about 2 that left the South Georgia area, which is the access challenged area.
Etienne, is there a mathematical predictive model that the data can be applied to where you can remove or add centers in different geographic locations and look at access? I think is what you're asking. Is there some methodology for that?
Well, it's not a mathematical model, GIS mapping is what you use. You can take out hospitals and see how the map changes. That would be relative, assuming there's relative.
So you basically have to redo region 2, 3, and maybe 10 because you added 1 and you lost 1. You'd have to
Right. So it's easy to plug in a hospital and see how well they serve. That's what,
yeah, you're right.
Right, I mean,
Right,
that's
yeah.
huge.
Yeah, that is huge loss. Yeah.
Right. Not all regions, but the impact. I mean, we knew about Northeast Georgia.
I know you're tired of, we have more questions at the end of every round.
I'm here for.
Any other questions from the commission or the audience? We're ahead of schedule, so we have plenty of time.
That's a lot of data to absorb, and there was more, so you can think, tree over there, trimming this. A little bit. But I actually don't do it if you have time, again, feel free to email me. When you have questions.
This is just a curiosity to me. I noticed that when you were going through the region data, most of the regions had a dip in 2016. Was that just a way of methodology in collecting data?
2016 was the first year after the transition from IC9 to IC10, so it may have something to do with that, the reporting systems. But yeah, very curious. We don't know beyond that what could have cost them. That's what the data shows us. But that's the only thing big thing that happened that could explain.
Do we, from a systems of care perspective, do we look at this data in conjunction with the surrounding states? I say that because Tennessee's got one right on the border. Grady's a part of Brems, so we are part of the Alabama trauma system already, and then Florida. So I just wonder from a systems perspective, looking at us in silo, correct, but your bubbles are all over the place, and how do we relate to that from a trauma patient perspective and outcomes and access? Just curious if we've done that.
Right, well, that's I'm not sure what kind of arrangements Georgia EMS has with these systems in the neighboring states. When I talk to the folks in Florida, they all talk about we need to talk to these people.
We need to.
I'm not sure if any conversations ever take place.
Okay. I just wasn't sure if that had happened and if you were aware. I just think that there's value when we think about, because can we just plop in another trauma center? We'll probably not just do that overnight. So, but if we have access for our patients, you know, what type of relationships and transfer agreements and other things that result in that. So just an observation.
But remember, of the 733 Georgia residents who were classified as trauma orders in Florida, 40% of them were transferred from their hospital. I have a sneaky suspicion of the hospital in Georgia, there. They stayed in the patient and transferred them to theirs.
Okay, this will be posted on the slides will be posted, everything right there is on our website, commission website, so you can have access to those. If you see something you want us to research or get a great idea or you see a gap and you have a suggestion and you don't have a suggestion, just notice a gap or something we can improve on, we certainly welcome those comments. We can sort of go over those. Thank you so much. Another great job really analyzing our system and give us a lot of good thoughts. Thank you.
Thank you.
Okay, well, as I said, we're ahead of schedule, so why don't we take we have a
break built in. Why don't we take a 15-minute break and we'll reconvene here at about 5 after.
Our budget that we had not done, we had not done that. We got that done. I think everybody is paid at this point. You know, it's working there. So, contract process, if I may be changing that somewhat. We have significantly increased our funding for initial education. A lot of those courses are being done as ETR courses. A good many of them are actually going to the EAT class. The initial effort with that process and then teaching EMRs, which is the first medical responder, usually called first responder, and because of the workforce shortage, many of those agencies are now upgrading at a little bit cost for them to the EMT class so that they can use those as licensed ambulances. That is a huge plus. But it's also kind of a bit of a minus because those particular fire agencies and other folks who are recognizing EMTRs or EMR classes so that they would have folks training initial response. That is gone down somewhat. So that has concerned me a little bit when we're looking at that. I'm very interested in getting my hands on this data. Because I want the state has shared with us some good data about where these classes are actually being done. We've got maps from what they presented to MSAC a couple of weeks ago. So I'm very interested in looking at where these classes are being done and looking at Dr. Frank's data about travel distances and travel times. And because, at least in my perspective, those agencies have a much greater problem. Because if they're an hour and 15 minutes from a trauma center, then you got an initial response, treatment scene, an hour and 15 minutes, whatever, to get to the trauma center, turn around and get back into their community. That's the time on task, and it can be 4 or 5 hours. So it's really a challenge to this. So I want to look at the data that they gave us, and the data Dr. Pratt provided to look at where are we doing EMT and MTR classes in those regions or in those communities? If not, how we can kind of help mesh that. We continue to fund the automatic vehicle locator system. For those of you who don't know, these are devices in our ambulances that can be tracked. The 911 centers can see where they're at. State and disaster situations can see where they're at. They can use a Wi-Fi hotspot in there to transmit data back and forth. I think the pilot program in Northwood is trying to use that capability with their ultrasound pilot program. But I think one of the great things about it is at this point, only 8 counties in the state of Georgia of 159 are not in that system now. There's 151 counties in the state of Georgia have this system. And we're paying for the vast majority of that. The EMT online training will continue to work on that. The inter-hospital transportation is one of our key components because that has been identified on several different levels as a huge problem in our systems of care. Because if you have that trauma patient in a rural hospital and you can't get into the trauma center in a timely manner, that's a huge issue. We have worked somewhat with the Georgia Hospital Association. I've been involved with that. The State Emergency Medical Services Advisory Council, which I'm on, I've been appointed as a chair of the group to look at that. I think Liz and I have been working with Nina Hamlin, State Office of Rural Health, and we work with level forces. I think Dr. Patterson will speak a little bit more about this, trying to do a survey on these rural communities as to what they have and what they don't have, and hopefully include what their transportation capabilities are. And I think that's one of our key issues going forward. So I'll answer questions that you have.
Coordinator, just one question on the great report. Thank you. On number 5, the inter-hospital transportation talks about, I hadn't had a chance to catch up, but requesting legislature to set up a joint House Senate study committee. Is there any traction on that, or is it before? Thursday, I'm supposed to be at the Capitol. I spoke on a bill maybe 3 weeks ago. I was yesterday. That was that. But I did mention to them the need, and that this Health and Human Services Committee I did mention to them and ask them that we need. I think that's desperate right now to look at the EMS world from both the House and Senate side of it. Several years ago, I guess 2007, we did a Senate study committee. We came up with a lot of recommendations, and many of the recommendations that were made were acted on. And today, a lot of those are crisis statements within the EMS world. It's not just the rural areas that are having these issues with workforce. It's urban and rural. The other piece of it is the funding. Medicaid, which is a pretty good portion of that. Medicare pays ambulance services less than the total cost to run a trip, and Medicaid pays less than that. And when you look at the trauma numbers, the percentage of those that are in care paid, and you realize both of those payers pay us less than the total cost to run a call, and that's difficult. But yeah, we're meeting Thursday, the U.S. legislature today, and I hope to talk to some folks up there about that. Because I think if you look at all the pieces of the puzzle, 15, 20 years ago, EMS was about ambulances. It's not just about ambulances anymore. And I have friends who say, well, just we pull out here, do this and that. But there's a lot going on in EMS, office EMS, and our EMS world, particularly systems of care and trauma and stroke and cardiac, pediatric, all of those pieces to the puzzle, you look at it and how do we get that critical patient from rural Georgia to the trauma center. And I hope that will happen. When you talk to the Senate, please say they won't try to do that, because we're trying to get that message across.
So we're saying a study group on transportation would be one. Because we saw from that now we have some very sophisticated data that the study group wouldn't have to start from scratch. And then obviously look at your testimony. And that's how SB60 was formed, the commission was formed. It started the study group, 5 members from the House and 5 members from the Senate. And we heard state and national experts testify as to what the need was. So I think there needs to be a focus on transportation for systems of care with EMS. And we may not get anything done if we don't have a study to look at what the gaps are.
And when we did last, like I said, 2007, because we have friends in the Senate and they're great friends, but when you sit back and realize that money bills come out of the House, so I have to choose over a House bill or a House resolution. But I think it's better to do it on both sides and have both groups. I think they don't understand. And they really, most people don't understand how complex EMS is in the development of the systems. Ambulance services are not complex. Okay, you call, we haul, that's all. That is not that difficult. But if you're going to put together a true EMS where you're working with systems of care and you're doing 12 EKG interpretations in some hospital, and you're doing interventions on trauma, needle decompression, and making that, the clinicians making that determination, can I make it to a level 1 center, or should I go to a local hospital and get blood or chest tube? That's not insignificant. And the unfortunate thing is when I spoke to the legislature several weeks ago, they were looking at a bill where the people who wrote the bill didn't understand. I mean, there's things in the bill that just would not work. So we need to make sure we try to educate them, and I think the Joint House Senate subcommittee would be the way to do that, because when they do that, it's not just us testifying. They get experts to go off. They have research folks who go all over and look at other systems in other states and how they work, comparing to how they look at best practices across the nation. So think that would be great. Very good. Any other questions for him? Thank you, Gordon. Why don't we move into the budget report now, Dr. Medeiros?
Thank you, Dr. Ashley. Good morning, fellow commission members. Our budget committee report starts on page 33 of your packet. And I will start off actually referring to Katie, who can go over all our updated budget documents that you have. She can do it in a more concise manner. And then when she concludes with that, the budget committee has two proposals to bring forward for consideration for the full commission. Katie?
Thank you, Regina. The first report we have in the booklet is the timeline. This has been in the works this year with the trust fund. There's been some changes since we don't have an AFY budget, so this is a working document. The next one is our expense to budget. We keep up with this monthly on our budget committee meetings. Everything is in line. If you have any questions, I'll be happy to answer them. I'm going to go line by line. The next is the super speeder revenue summary. And as you notice, the trends are following the same trends that we followed throughout the years, especially 22 and 23. This is the comparison of 22 and 23. We're starting an upward trend like we did in 22. So that is lowering the gap of our cumulative variance that we started out with for 22 and 23. Next report is our FY 2030 funds to allocate. We call this reallocation, but not all the funds are reallocated. But the first line shows our firework revenue that we normally got at the AFY, but we are not receiving that at our AFY budget anymore due to it going through the Department of Revenue.
Maybe let me interrupt you for just 1 second. What she's referring to is the updated handout that you guys have, and it will be tied to a motion that we'll bring forth. I asked Katie just to explain. It took the budget committee several iterations and lots of questions to understand what we're asking. So it's the sheet that should be in front of you guys, a single sheet, not the sheet that's in your packets. Make sure you're looking at the right document. Sorry, Katie, go ahead.
No, that's fine. And the one on the screen is the updated one. The first line that we have is the firework revenue. Just summarizing that, that is coming from the Department of Revenue now, not in our AFY budget. The next line is our FY 23 reallocation funds. These are funds that were unspent for FY 23, so these are actually reallocated funds, which came to a total of 1.6. And then the next line, the 1.5, is our FY 23 trauma center funds to reallocate. The next box shows our proposed allocation plan for those funds. So the first 1.6, we wanted to up our contingency for any unknown expenses such as meeting expenses, for our PSO attorney, and our Stop the Bleed coordinator. The remaining 1.4 then was distributed by our split that we do our budget for trauma centers and EMS. Then the next 1.5 for the trauma centers, we're going to increase our level 3 trauma centers by 75,000 and our level 4s by 25,000. And then the rest is going to be distributed by the formulas that we use to distribute our budget for the trauma centers. Are there any questions?
Yeah, I think we'll pause there and let everybody digest that. I know it's a lot of numbers there. It's very different than the historical budget cycles that we've dealt with in the commission because we no longer receive true AFY funds. The AFY budget does not include us, so we'll get our money up front, and then the slight change in, I forget how you word it, but the funds, fireworks revenue. It won't come right at the very beginning, but it will be a deposit directly into the trust fund. So we are doing full budgeting at the beginning of the fiscal year, so it's very different than before. And that's why we have a little bit of money. It came late, the fireworks this year, so we have that plus the unspent reallocation funds that we typically have every year. So you can see those proposals broken down, and the bottom half of the funds come from 2 centers that are no longer in the system, and so we'll be redistributing those funds to the existing trauma centers that still are within our system. So I know it's a little confusing. I'll give you a minute to look it over. And then I would like to entertain a motion to approve the reallocation spend plan and open it up for questions and discussion.
So it's coming from the committee, you don't make a motion. So
I just need to make it.
you don't like any discussion.
Second.
You're covered.
Okay, thanks. Any questions? None? Wow. Maybe you did a good job.
Okay, then I'll call for a vote. All those in favor of the motion from the budget committee? Aye. Aye.
Aye.
And those opposed? Okay. Thank you.
Thank you. And we will be working with or taking up the 24 budget and the budget committee meetings. Unfortunately, I know I'm not very popular this time of year because we end up having to have a call commission meeting. We will do the same. We're looking at some financial projections and what the cost would be to bring all centers on board within the funding scheme, and what that impact will be and what that cost will be. So we'll be talking about that as well, and increasing the base stipend, which you saw in the AFY distribution. We want to do that going forward to the 3s and 4s as well. So it will be the additional funds that you see in this proposal on top of the base funds and the stipend they were getting before. So that's just something for you to begin to ponder as the budget subcommittee takes that up and brings forth the budget for you to look at and approve that. When did we think we would be? We had kind of a guess that we'll probably end of March, early April. Yeah, it has to be before the next meeting. The budget committee only has one other item that they would like to bring forth, or will have to bring forth for approval. As you know, we've always had performance-based pay metrics for trauma centers receiving their funds. We are moving towards requiring some level of performance-based pay for all contractors. So this is the next iteration of that you have before you. It's on page 41 in your packets. The contractors that we don't currently have this performance-based pay tied to, we were asked them. It was a collaborative effort to put forth some recommendations as to what measures would be reasonable. So we didn't just pick and tell them what we were doing. They were involved in the decision-making. These are the final proposed metrics for each of the contractors that we have currently in place, and what they would measure on and the percentage of at-risk dollars. So again, I'll give you a minute to take a look at that. And then on behalf of the budget subcommittee, I would like to make a proposal to approve the performance-based pay for these additional contractors.
This is in line with the AG's recommendation for ensuring we stay aligned with the state gratuities code and that we don't pay folks for not submitting things on time, et cetera. So many eyes on this.
Yeah.
Okay, any questions? Call the vote then. All those in favor of the motion? Aye.
Aye.
Opposed? So that carries.
Thank you. You guys made it too easy for me this morning. No harder questions. Appreciate that. Here's our report. Dr. Asher.
Thank you. Okay, at this time we'll move into level 3 of the Fort Worth Trauma Center meeting. Dr. Patterson.
Thank you, Mr. Chairman and members of the committee. Thank you to our latest report. We actually, our minutes in the meeting in your packet from our previous meeting. We also had a meeting yesterday that I appreciate the chairman and director being at. Currently, several things we're working on, especially since we've had a lot of information over the last couple of months from the Pennsylvania Common Systems Foundation consult and the ACS rule. Currently, we're still working on the March pause process. We have initial equipment delay, which all the equipment now is in, and we hopefully to have our first scheduled pilot course at the end of April. Gordon, Mr. Fuller, would you like to say anything about that? It's going to be still, our plan is to and for 90% first.
But we plan to be the first, and again, I'll tell people, I think the more discussion of participants is going to learn the most, but we'll let out like 28%.
What center are you, is that, or what region is that going to be in?
I'm sorry.
What region or center or location is that pilot project going to be in?
No, it'll be in Macon County, it's Region 6. Okay. But we're close to the region now.
Yeah, I'm just curious. Just didn't know where we're going. Okay.
And our second course would hopefully be Ordeal, Chris Regional, and then the follow-up with plan for the large ball, both of those centers in Region 8 to get that project off the ground. We've had two other suggestions. One to have a QR code assigned to the eventual project so that we can actually hand out cards or anything if we're interested. I would also like the commission's permission to actually post a introductory PowerPoint presentation on the GTC website about March Falls once we get the pilot course done and kind of at least perfected in its first iteration so that people can come to the website and actually see what the course is about and ultimately request the course to be given at one of their facilities so that we can start to market the course through the GTC at some point. Other things we're following up on the ACS consultative rural visit was a huge success, I think, with the participation that we had. Currently right now, from our standpoint, we have 29 rural recommendations, 8 priority recommendations. At our meeting yesterday, we tasked our members with reading the final report when it is out in early April. We have a meeting scheduled for April 21st, because ultimately we'll start to dive into some of those recommendations and start to hopefully develop some work groups for the 8 priority recommendations so that we can carry those out. And set up those work groups hopefully by the summer meeting in August and start to have individual work group meetings for those over the next couple of months so that we can bring some initial plans and discussions to the August meeting. We would like to have ultimately a 90-minute to 2-hour work session at the August meeting to get together with our members, since it's much easier to do things in person at that point. And we'll hopefully come back with to Dr. Maderos and the budget committee for some budget proposals in August to tackle some of the initial issues that are there. We don't have anything concrete at this point. We are continuing to do our access to specialty care update, which we'll do in August, which will be our second update to allow the level 3, level 4 centers to see what's available in the level 1 and 2 centers across the state, such as ECMO, replant, have numbers at their fingertips when they need to call the burn center in Augusta or the burn center in Grady or the ECMO availability across the state. And then in response to that, we want to be able to do a survey that we tentatively call the Central Resources and Demographic Survey of the level 3 and 4 trauma centers so that everyone knows the resources that are out there that we have, so they may be able to volunteer to help us out in a certain circumstance, or to understand why we may be calling because we don't have an available service at that point, that we need to transfer a patient that may not necessarily meet transfer criteria at that point since we don't have a service available. So we want the level 1s and 2s to understand where we are. We want the level 3s and 4s to understand what the level 1s and 2s have available. We'd like to start doing that hopefully on a year-to-year basis as well. Our web-based ESO registry and contract abstraction services are on the go. All the funds have been allocated, but not yet utilized, and we're going on through that and trying to follow up with centers there to get all that stuff on the ground. The level 4 services are being rewritten at this point, or as far as the initial programs. And we appreciate the board's support in that matter as well. Now, as far as other topics that we discussed yesterday, we're still digesting the PPSF level 4 consult visits, and of course the ACS consult visit, which we just mentioned. And ultimately, we're trying to come up with action plans related to those things with the commission itself. Our next meeting is scheduled for April 21st, and then we'll have another meeting in between April meeting and also the August meeting to continue our work. I think we've done very well for the last year and 3 quarters, and we want to keep that momentum going with the help of the state. Any questions?
Great report, Greg. And like I said earlier, really like enthusiasm of reading all the full checks. So
thank you, sir. Appreciate it.
Okay, this time we'll move into the GCTV report. Tracy Jones.
Good morning. We've got, I'm excited to say, a level 3 and 4 work group for the GCTE program managers and administrative staff. This was created after the November report where the PT Pennsylvania group reported out. They have met a couple of times, and they have 2 goals for this year. One is to develop PI plans and understand that, and we began to address this yesterday at the end of our meeting with a presentation on what a PI plan looks like and just the basics of that. They're also going to be working on what Dr. Patterson just alluded to, using the PI module or outcomes module with the registry. And this speaks to some of the deficiencies that were noted by Pennsylvania. The registry group has been very active, and they've done a lot of organizational things as far as the contact list being updated. Trauma data management plan has been presented in one of the meetings just to tell them this is a new requirement of the new standards, tell them what that looks like, and they're forming a Georgia Data Dictionary work group who will make sure that the data dictionary gets upgraded every year and that any new data fields are defined. Education, there are some requests there looking at trauma registrar education with ICD-10 procedure coding courses. This is a new requirement in the standards. We would like to offer something. Also, AIS certification is a new standard, and establish at least one in-person registrar meeting. If we can, beginning this year, that may have to be virtual because we don't have the funding for it, but if we could get some budget money. They don't have a group, supportive group. Yes, so we're all attacking Dr. Medeiros. But we need to really invest in our registrars because data is at the basis of all we do, as Dr. Craig showed us, whether it comes from the registry or from other data sources. And I think that's just going to behoove us to go forward and really look better on our benchmarking reports. Because as a facility, I've seen that as our registry has tightened up, the validation comes in. The more we educate our registrars, I think the better we'll do, and the more we can use our data in a meaningful way. We have started talking about conversion to AIS 15, but that would be at least 24 to 36 months ahead of time. So one thing that we have to think about is possibly setting a goal date to do that, and then also giving people a chance to start working toward that, because that means they have to go to new software that does support the 2015 AIS coding, and whatever system they go with, the ESO software or others, it's going to be pretty expensive because AAAM is now passing on costs to the vendors who are passing on the costs to the users. And that's not been a big factor in the past as far as the cost of the registry. Injury prevention and outreach, they're always on the go. They've created 4 webinars, one for each task force for virtual training with Georgia Stop the Bleed. bingo signs, which is ball prevention, but putting bingo in it. Events for preventing trauma like road ahead and child abuse prevention. And a framework has been put together. I think Liz has gotten that from Crystal as far as how to apply for funds, a little more structured, so that, you know, it helps helps the committee and the commission understand what's being asked for. The PEDS committee has been very active. They're looking at SIPA scores. So we heard Dr. Joseph talk about yesterday. Shock index is very important in geriatric patients. It's not just the pulse, or it's not just the systolic, but putting the two together and looking at shock index. Well, there's a pediatric shock index. And so that's something that they're looking into. I think ACS surveyors are looking at that when they do surveys. And so they're looking at that, or a modified SIPA score. They're helping with PEDS readiness courses. And with the committee that's looking at helping to equip rural facilities being ready to take care of pediatric patients. The other thing that they was reported, CHOA did a review of 2020 data, and they looked at almost 1,600 transfers into CHOA, and 34% of those were discharged from the ED, which is a concern. We've heard that in different reports, whether it's been today or yesterday. And so they're working on that to maybe drill down and see what are the most common injuries that are getting discharged, and possibly looking at putting that into a Georgia Pediatric Virtual Consult program. And also using the Georgia Pediatric Transfer Toolkit, which I think is on the ACS website or the STN website, but it's something to help with that. So that'll be coming up more as we get that data. The Education Committee has gotten a lot done. They've got the first draft completed of reducing time to transfer. They've got some information on AKI, and they're on track for first draft completion of that. And they handed out little TCRN study guides to people who were at the meeting, or they mailed them out, and trying to encourage people to study and get certified as a TCRN. Overall, the things that we would like to put before the committee is possible budgetary support for outcomes registry module, but I think that's been handled through the level 3 and 4 committee. They're looking at who does have that support, who does have that outcomes module, and if they don't, trying to resolve those things. But we are looking for funding for the education, as I mentioned, for the registrars, AIS, and ICD-10 coding, and also really prioritizing level 3 and 4 staff, because they have fewer registrars, so give them priority seats at the table. And then I think that's it. So the motions are just the budgetary support for the education is the primary thing that we're looking for consideration. Thank you.
Okay, just a follow-up as we move forward to work into the FY24 budget. If the GCTE could come up with a proposed budget specific with line item and anticipated cost and dates that you think you'd like to have the courses and edge that, if you could submit that to the budget subcommittee, that would help us to make some clear decisions and be more specific in our support of what your needs are.
Okay, we have that available. Who specifically do I need to just send it to you? Okay, we've got that. What we thought might be easier is maybe not have a specific course, but just fund certain seat, a certain number of seats, right. And that'll help staffing wise spread it out through the year. But I think Kelly's already gotten most of that together. We'll just put that.
So seats in the existing virtual courses throughout the year. Yeah, but if you just have the total dollar amounts.
Sure.
Yeah, and I think it's instead of what would be the easiest, I think, is to encumber the funds to the entity that does the course, so that we're not having to give the individual individual trauma centers. Okay, money, that's really the easiest, so, and we could always, you know, add funds to it, so don't panic, like if you have registrars that need a course, or if we want to do something like a rural topic or something like that, we can always like add to it, but it's important to establish them as a vendor, because I think the one that we checked wasn't a vendor yet, or maybe we had paid the trauma centers in the past and not the actual entity, or Palm Free or something.
That was first. So you would specifically be looking probably AAAM.
Right, AAAM, and then I'm not sure about the ICD-10 course. We discussed Palm Free and ATS, but I'm not sure the logistics of that. So we wanted to check to see what would work out easier as far as the administration.
Tracy, just a quick question, and I may be overthinking this, but do you have an idea of how many centers outsource their trauma registry to a group where the registrars are not on site, but they're remote or virtual? And does that play into, if that's a contracted position or a contracted group, how does that affect our ability to train those people or supply training? What does that do from that statement?
I don't have that information, but you could get it. I think it would be interesting. Now, there's two things there. Like if you talk about employed remote versus contracted remote.
I'm talking primarily just contracted, because employed is employed whether they're in the hospital or not. But I'm just worried about how the funding would work for training a contractor versus, because you already got a contract for that person to do a job.
We did discuss that, and more or less, we weren't thinking as far as the contracted. I think we were concentrating more on the employed registrars. I know at my own facility, we try to include them, but because they are paid a premium price, we expect them to come to the table with those certifications.
Yeah, you want that in your contract.
Yeah, that's why I just want to make sure. Once again, overthinking it, but that's fine. All right, thank you.
Right. So, but that is a good thing to point out.
Thank you, Tracy. Thanks for GCD and so much heavy lifting. We appreciate it. Okay, at this time we'll move into the rehabilitation committee report, which is a new report. Dr. Ford Fox. So, Dr. Fox.
All right, howdy, folks. So, the rehabilitation committee is a new concept for the trauma commission generally, but included in the past couple of trauma system reviews. We've been asked to convene. And of course, the important kind of other half to the trauma enterprise is the rehabilitation phase. Of course, we have this focus of trauma survival. And after survival comes ultimately, we hope to prevent ongoing disability, return people to full function as possible, and to functional independence. So the concept of a rehabilitation committee, this enables us to get the key stakeholders in the state, namely the rehabilitation facilities, the rehab hospitals, professionals in the state, kind of on board with the trauma commission and looking at that data from this rehabilitative perspective. And we're able to kind of hopefully going forward, roll up our sleeves and dig into some of these priorities that the College of Surgeons has identified. So it's specifically stated that Georgia has a strong asset in the rehabilitation world. You know, we do have some very strong rehabilitation facilities here, Shepherd Center, Wellstar, Emory, and many others, and we're gathering those together. But it's been listed as an issue that we've not been integrated into the trauma system thus far. So we're going to look for ways that we can better integrate the rehabilitative phase and similarly share the goal of improving the quality for rehabilitation for the trauma population in the state and making sure that the rehab phase is meeting those needs and perhaps offering guidance to the state and policymakers going forward based on analysis of the data of where these gaps lie, just like we look at the gaps in the EMS system and so forth. So we convened our initial meeting last week, had pretty good attendance from a variety of facilities in the state, and expect that our next meeting in May will even be larger, hopefully adding a couple of more facilities as well. In our report, I'm going to go through the priorities we've identified thus far. This is, of course, early days, literally the first meeting, and so just kind of talking about additional ideas that we can do and so forth. We began digging into the data with regards to the discharges. Initially, where are folks going after trauma? We're going to start parsing that data by the injury severity scores, and of course the key diagnoses in rehab world for disability of traumatic brain injury and spinal cord injury. I, of course, come from Shepherd Center, which happens to focus on that patient population. It's a 152-bed facility, currently about to expand to 175 in 2 years, then expanding to 200 beds by 2030. It'll be one of the largest rehabilitation hospitals in the country. And it's, of course, a national rehab facility that's treating patients from throughout the country, but certainly a sizable chunk, roughly a third, from the state of Georgia. And we have a large research department, and I'm going to get involved in this committee as well. We're going to put someone on the GQIP as well, and really help look at this data. My role at Shepherd Center, in particular, just to introduce myself, I'm the medical director of our Disorders of Consciousness program. The Shepherd Center has the largest program in the country, receiving patients who are still in a vegetative or minimally conscious state after a traumatic brain injury. Fortunately, the majority of our patients do ultimately regain consciousness. Of course, some do not. We train families, do everything we can for the patients, ultimately do get the majority home. I have some other hats as well. I'm in charge of continuing medical education there in the ethics committee. Happy to be the representative spearheading this program for you guys. Now, so we're going to dig into the data and try to answer these ACS goals and so forth, and look at things like DC delays from trauma facilities as well, and where people are going. Are these insurance or other issues or capacity issues and so forth and so on. Try to look at the scope of the problem in terms of disabilities. So, you know, our Medicare, Medicaid applications are kind of a good initial metric, kind of digging into these key trauma diagnoses and thinking about really making this problem salient for state legislatures and folks who are kind of looking at the financial aspect of it and so forth as well. Can we bring rehab facilities into the database as well? I think so. We're going to look at ways that we can potentially do that. Really look at these outcome numbers. Rehab facilities do have a lot of that data and ways to contribute to that, the types of disabilities that we're seeing and the resources that are needed down the line. Could there perhaps even be a level system for rehabilitation facilities? Rehab hospitals do have obviously their own forms of accreditation, as well as the different types of programs they offer. Do we have enough of that in the state? You know, could we look at perhaps designating something parallel, also perhaps motivate these programs and facilities to participate in the quality improvement data? It's like, you want to be a level 1, this is what you got to do, et cetera. And then, you know, look at just resources in the state generally, try to integrate with key agencies like the vocational agency and so forth with regards to the trauma population in particular. So that's kind of our slate of topics thus far. The key item that we have for the commission at this point is to officially establish the committee to ask a motion for that.
Any questions for Dr. Fox? This is a new committee. I think you've been very productive with your first meeting, first and only meeting. Congratulations, and we look forward to a lot of great work and, you know, and we'll provide our support. Any questions, Dr. Fox? Okay, well, thanks. Oh, yes, I was just sorry.
So I guess the question is, do we need a motion to make this support?
Oh, that's right. Thanks for bringing that forward. Of course, we do.
I'll respect that motion.
Okay, can we get a second?
And I would second it.
Okay. Any further discussion? all those in favor of making rehabilitation a last committee? Aye. Opposed? Okay. Welcome aboard.
I just wanted to say, they didn't ask for money. No. And I think we should write this time, we don't warm it up. And included in your packet is a nice letter that Dr. Bach sent to all the rehab providers. I think that you knew at the time to sort of describe what was going on. So it was really well thought out. It's so great that you were able to participate in the ACS consult, because you were able to frame that really well, so they kind of understood what they're getting themselves into. But the more we can bring to the table, I think the better, and then connect with you and GQuip as a database, and however we can support. Thank you for agreeing to do that.
Okay, we'll move into the Trauma Administrators Committee report. Dr. Michelle Wallace.
Thank you. So we met yesterday, but before that, one of the deliverables or requests of the administrators group was the ability to communicate when a trauma center wanted to be on transfer diversion, but was still accepting ground and helicopter. So that was created within the GCC system, which has been utilized across the state. The GCC has been. It was created, it was trained the end of November. We had 11 centers that participated. It went live in December, and we've had it used 3 times. As with any new education and rollout, you always need to do a little bit more re-education. So we are going to be sending the education. The request yesterday was given to be able to send it to the experts in the trauma center, which is typically your 2 p.m. program manager and director group, tend to know everything. So we're going to send it to them, as well as sending it to the administrators group again, so it is available for use. That is only seen by hospitals, so it is built so only the hospitals can actually see it, so there's no confusion for our EMS partners. We'll be looking or have been looking at that. The second thing was around trauma system communication and plans. So divided into 2 separate situations. One, the communication we use around diversion and saturation. There are 18 different types of communication around diversion and saturation. Reality is the only one that really counts is diversion. And so the admin group will not be driving this. This will actually be ran in conjunction with GHA, BPH, hopefully a few centers from the trauma center perspective, to standardize those definitions so there's consistency across the board. When there's 18, nothing matters. Really, the only thing that's going to matter to EMS is who's on total diversion, and even then, it may not, if that's the only place that they can go. So standardizing those definitions. What does impact the administrators group? We are moving, the GCC is moving to a new platform with Image Trend. It's been a little bit, anytime you roll out an IT process, there's always stops and goes. So we're hoping, we're told within the next 30 days that will go live. When that does go live, we will have the ability to have communication plans throughout, and actually anybody, within both trauma centers, non-trauma centers. And so one of the challenges we have in our regions is the ability to effectively communicate versus having to text or make a phone call as to the status of the hospital. Within Image Trend, we'll actually be able to create message groups so that when something happens, there will be an automatic message sent to whoever, the individual hospitals or EMS, whoever want that information. So there's 2 groups being built right now, and what we will be asking, we asked yesterday, I'll be sending a follow-up email, is for the administrators group to help us understand what they believe their communication plans and patterns need to be. We will actually work with our trauma medical director group so that we're all communicating effectively and we don't have 2 different silos in those to figure out what that needs to be and what people want to know. At the end of the day, what do you want to know? What matters to you? And what regions need to be, because EMS regions are not really effective. We saw that today in the presentation. They're effective. The communication isn't siloed to just one region. A lot of our region EMS folks cross, and we would not want to leave anybody out. So I think that's the big next step. The finance work group, we finally have some folks that are participating in this. So there's 3 main objectives. Regina and team Katie all help support this, so I appreciate it. really around education, engagement in education. It is not intuitive. Trauma finance is not intuitive, even to the finance people in hospitals. And so I'm thankful, I'm sure many of you all will be thankful, that one of the representatives actually came from Gwinnett, had done a tremendous amount of work on their codes with Gina when she was there. And so she's a part of this. And then the second piece of that is the understanding how we're using our funds and where that's being allocated to. I do think that from an administrator standpoint, part of the meeting after the meeting yesterday, conversations, this was a topic because we may not, it may go into the black hole right now in most places, it's going into the black hole, but you actually may be spending more than what we're receiving from the commission. So I think there's something there that we have to look at, particularly as programs have grown and been added over the last few years. And then the Trauma Center funding distribution, they will work with, but that's going to be in liaison with our GTC partners around that. So the best part of yesterday, I think, is with some meetings, is the meeting after the meeting. Multiple conversations. So we actually have 3 agenda items already for our next meeting in April that have been brought up from a number of the administrators, just some questions that they've had. So great conversation and just excited to see where things go moving forward with that. That's it. I'll take any questions.
Michelle, was there, you alluded to it a little bit regarding the money from the money that the Trauma Center brings in from the Trauma Center perspective, and where does that money then go? Because the commission obviously allocates a significant amount of money to each Trauma Center, especially for the medical readiness and the unfunded care, uncompensated care fund. So is there been talk about how to better track that?
That's part of one of the deliverables that they want. The finance work group has had discussion about is how do you track that? I think partially, if the commission never delineated how we wanted that reported back out, then we're going to have to backtrack a little bit. Most centers I've spoken to, it does just go into the black hole. I think there's some best practices out there. I know of at least one place that is allocating their dollars effectively and have used that to work with their finance team to be able to take the education dollars and utilize it towards education. So I think that it is happening, it's just not happening widespread, particularly probably for your older centers that have been a part of this for a long time, and your bigger centers, if that's where it's going. So really understanding, and we have to be clear from a commission standpoint what our expectations are. So we can't just say we want to know, like how do we want that? And maybe that's something that needs to be reported out from the center so we can quantify that, particularly if we're talking about oversight, financial oversight, mistakes on those. And so what does that need to look like? So great conversation.
And they do actually report it as part of the requirement for their, one of their quarterly, is it the final one?
No, I think it's the third.
Okay. But we actually try to make it easy, Michelle, by making a check box. So I think we're not kidding. I think people are just like, I'll be honest, like
I know they're not, because I know we're not.
I would check the box saying like call pay, because like whatever you gave me, it was never enough to cover.
That's right.
So, yeah. And I think, we have our own data that shows that we don't invest enough in injury prevention and education. So right there, that shows that maybe we should say that a portion of it, without being too dictatorial, but like if you're not doing those things and you're getting money, you probably need to address that.
Okay, thank you, Michelle. We'll move into the Trauma System Performance Committee report, Dr. Dunn.
Thank you, Dr. Ashley. Very similar to what Michelle just presented. As the State Office of OEMS and the T, you guys got to get a better name because that's very difficult to say. So they have been converting over to ImageTrend, and that has affected our ability to analyze the data at a state level from the ditch-to-door mechanism. That's the whole purpose really of our committee, is to try to figure out how long it takes a patient in the ditch to get to a designated trauma center. And so we had some initial data, which was about like maybe 5% or 10% of really the whole pot. So we wanted to try to get a bigger sample size. And so we're about 2 centers away from having that conversion from the old system into ImageTrend. And then once that gets complete, then we start building reports to be able to pull that data out. In the meantime, because I'm a trauma surgeon and I have like 0 patients, we're going to do a separate study for Ditch the Door between 2 of the level 1s in the state, Region 5 and Region 9, Dr. Ashley Center and my center. We're going to pull our own data because we as a specific center have all that data already in our registry. So we're with the help of Tracy Johns, the trauma program director at Macon, and Whitney Williamson, my trauma program director, we're going to pull that data and then analyze it. We're in the process of getting an IRB set up. I actually had to already pull that data from a PI standpoint because our center is coming up for verification for the American College. So we needed that data from a PI room closure standpoint. So hopefully within by the time in our next meeting in August, we'll have some preliminary data on what those 2 centers look like, depending on how fast the IRB center can come through. Then the last comment is the armband, and we're still not even into the pilot program yet with the armband. That has been a lot more detailed and cumbersome than we initially anticipated. We're just about done with the training on with a pilot project, and now we got to figure out where to put that number in the registry so that we can pull that out and link all those centers together. So this has been a long time in coming. I think the persistence is going to win here because I'm not going to let this drop. So we're going to eventually get the answer. I may be retired and I'm wheelchair, but we're going to get this data for sure. So that's my report, sir, and we're in the process of hopefully going to have some hardcore data to present in August.
Okay, thank you, Dr. Dunn. This time let's take a 10-minute break, and then we'll reconvene with the Georgia Trauma Foundation and finish the morning session.
At our infrastructure and determined that there were some things that we needed to do that would improve our accountability and our financial transparency. So yes, we all know it's important for the commission to know what's going on, but it's something that is equally important for our future donors. Financial transparency is the one thing that will help us not only earn trust, but it'll also help us keep trust from those who decide that they want to invest or support trauma. We want to get their initial gift, but we want them to continue to give without questioning whether or not they can trust us and what we're doing with the money. So as a matter of both ethical leadership and legal compliance, we need to have all of our ducks in a row. So we adopted some new policies and some better reporting systems that are in line with nonprofit best practices. These changes are changes that are also going to make it easier for our board members to fulfill their fiduciary duties. In the way of updates, we are continuing our work with fundraising consultant Alexander Haas. At the previous commission meeting, I shared with you all that our key messaging is minutes matter. Well, we already identified a short-term fundraising project, and we've been working with, or Alexander Haas has been working with our board to prioritize a long-term project. What the board has decided it will do before making any decisions is to wait on that final report that will be coming up from the ACS Rural Focus Consultation. We're going to take those findings from that report and work closely with some of our system partners. From there, we will decide which projects are going to be not only attainable, but those that will make an impact. When we get that information finalized, we'll begin to put together individual fundraising strategies that will support what we consider to be the priorities for the system. As we wait on identifying those long-term projects, what you should look for is we are planning 2 fundraisers by the end of the year. Instead of the one fundraiser we have been talking about, which was the gala in Metro Atlanta, what we'll be doing is holding smaller fundraiser or fundraiser events in the RTAC regions. This will allow us to do something that we believe will be more effective in the long run will create a more intimate and personalized approach to donors in those respective regions. So this will help not only raise our profile, but get the community more plugged in and aware about trauma care and the importance of what we do as a foundation to support the system. One of the other things that we will continue to do, in addition to having these special events around the state, is we are going to continue to pursue grant funding. We just completed the work for the first year of grant, and that totaled $460,000 for that grant award. Initially, our grant writing efforts will be centered around trauma education. This is because we have a successful track record with education, and that makes it easier for our case for support. It makes it easier for people to see if you've got something that's proven, they can go ahead and give you dollars to support it, and they don't need to guess how they're going to make it work. Another area that Alexander Hass has been helping us with is board development. I don't know whether I mentioned it to you all before or not, but what they did is identify that as our top internal priority, board development and growth. They provided us with a 5-step plan to design and retain the best leadership. And you've heard me say it before, and I'll probably just say it one more time for good measure. But our board is in the process of identifying potential board members. And the reason why I say, I'll just say it again for good measure, is just to let you all know that this is an ongoing process. It's something that we'll be doing all the time, is identifying potential board members and creating a good pipeline of candidates. I also mentioned before, but I didn't press the issue, that Alexander Hass would like the commission's input on potential candidates. And since I haven't heard from anybody, what I'll be doing is probably reaching out to you all individually. I'll let you know more about the skill sets that we're looking for so that we can put together a more effective and well-rounded board. It would help if you had a relationship with the people, but it's not necessary. Helpful, but not necessary, because what will happen is after we identify a group of potential candidates, Hass will work with us. And what they're going to work with us on is developing individualized cultivation and solicitation plans for each of the candidates. So it's a vetting and wooing process that we'll be going through with each of these potential folks. We're looking for those who, of course, would be the best fit for the foundation, those who can give and get money. I said that we weren't just looking for those with deep pockets. However, Hass has advised us that all new directors need to be experts in raising money. So for those who would be good at supporting the work but don't have the resources for bringing in the money, we can still partner with them to do fundraising. But what we would do is engage them in regional fundraising events instead, or we bring them in to help with fundraising on a statewide level, but it would be without giving them a seat on the board. This will give us more, if you will, fundraisers that can help bring in money to support the system. We do want to add the right directors quickly, I'll say that, but with board development as well as our other priorities, we have to take the time necessary to get it right. It takes time because we are positioning the foundation for success. Our next steps, they're very crucial. They're crucial in determining our initial impact as well as setting the foundation so that we can bring in the millions of dollars needed to support the system. Our board has not been, but will be, a fundraising board. So to get us started, we have identified an expert in raising money. When he joined Hamilton Medical Center, he brought in $75 million within his first several years there. His name is Jeffrey Myers. Our board believes he'll be an excellent director. So our board president, Dr. John Leisure, is going to talk to his qualifications and what we feel he'll bring to the table as a board.
Thank you, Cheryl. Excellent job. As Cheryl mentioned, board expansion is a key priority for us. And part of the strategy behind expanding the board is to enhance the skill sets, as Cheryl mentioned, to those that are already on board. And also, as she mentioned with regional fundraisers, we want to make sure that the board is comprised of people from throughout the state so that there's clear representation, because much of trauma care, as we know, is local. And so one of the key things, not the most important thing, but one of the key things with Mr. Myers here that we're presenting to the commission for approval is that he is the president and CEO of Hamilton Healthcare Systems up in Region 1, and that includes Hamilton Medical Center. That's a level 3 trauma center. So his skill set in administration, his background in insurance issues as well, his location, and part of the trauma system as a CEO of level 3 trauma center, I think will make him a very vital addition to the board. We provided you with his resume in advance, and so I am presenting him for approval from the commission to be added to the board, the foundation board.
Okay. So then, can we get a second on that?
I'll say.
Any seconds? Any discussion? Okay, all those in favor, aye. Opposed? Like foundation has been moving.
Thank you.
Joe, any questions or anything? Any questions for Cheryl or Dr. Bleacher? I'd like to say great work. You all come a long way over the last 18 months or so. Really sort of revamping the infrastructure, the foundation, and positioning us to go to the next level for fundraising. So I think you're right. I think you're positioning yourself to do it the right way. It'll just take a minute, but I think quickly, I'm very impressed with how fast you've gotten Okay, at this time, I'm moving to the Georgia Quality Improvement Program, Dr. Todd and Gene Solomon.
So the GQIP report is in the packet. The first portion of our GQIP report looks for work groups, the AKI, opioid, and TBI work groups. Many members know that we're sunsetting the AKI and opioid work groups. TBI will roll off in the summer meetings. We're going to replace those with 3 new work groups. We queried the participants yesterday kind of about what they're pursuing, so we'll start establishing those and have the first meetings coming up soon. The second portion is really the benchmarking platform and data central site. A lot of headway has been made on those fronts from the data central site. The ArborMetrics program, as everyone is aware now, is a little bit delayed due to unforeseen delays in circumstances, but it looks like to be what I'd say the fall 2023 rollout, September 2023. We have made great progress. I should say Gene has made great progress as far as the data dictionary and a ton of work on that front. So more to come. It's moving along slow, slower than we'd like. From a peer protection and data use process, the PSO is kind of well in its works. Michelle and her team have done an amazing job working towards that, and so that's moving forward as expected. The Trauma Advisory Committee is a group of folks that I really rely on to kind of help guide what we're doing from a GQIP perspective. We meet monthly, met just before this meeting, we'll continue to do so, and we're probably going to have 1 or 2 members when we reach out to our rehab colleagues to add them to that advisory committee. And then the last thing is the GQIP Research Fellow. Eli Malarmar is our current fellow, finishing his first year. We have submitted a request for a second fellow that they would alternate, so we can overlap in years, and in doing so, revamp the job description of the research fellow and what that looks like, the expectations, and looking towards the next steps of that. And all that that is supplemented with more facts and data and reports. Be happy to take any questions.
Any questions for Dr. Todd? I'd just like to say congratulations on the great meeting yesterday. I think from my standpoint, I thought maybe the best meeting, I hate to say the best, but certainly ranks up there the best, or one of the best we've had. I thought it was a good mix between, there's a lot of data, we looked at some collaborative stuff, got some ideas where to go, work groups reported out, and we also had some clinical information, I think. I know with Dr. Joseph's talk, I'm going to take really his whole package and just insert it in our trauma center. 10 years of research is turnkey. Of course, that'll take us a while. It'll probably take us a year or two to implement. We have so much stuff. But anyway, I got a lot out of it. So
appreciate it. I think really having those keynotes come in and give us an outside perspective is really valuable. The other thing I would say for the summer meeting, really looking for the ability to the morning session have a closed session just for the equipment members when we start doing some case reviews. And so the reception from the participants seems pretty high on that, so we're anticipating doing case reviews at the summer meeting. Fantastic.
Yeah, that'll be great to build an infrastructure for that. And then I really enjoyed too the feature of trauma centers and sharing some of their processes for improvement. That was awesome. So I encourage, we have a lot of great work going on in the state. Everyone works from 1s to 4s, and if you're doing something great, we want to hear about it. I'm real impressed with the group that did the decrease the time of transfer out. That was a great project, and it deserves to be presented at a meeting like this so we can all learn from that. So please, if you have your centers, if you're working on something, send that in to Dr. Todd and Regina. So we can all benefit from it. So, thank you. Okay, at this time we'll move into the Office of EMS and Trauma, Ms. April Moss.
I'm as far away from this as I did, so I can cross all. I know a lot of everybody in this room probably does not know who I am, so I'm going to introduce myself first. I am April Moss. I'm the Deputy Director for Systems of Care. I'm newly hired the Department of Public Health, the Office of EMS and Trauma. As most of you know, Renee Morgan retired at the beginning of this year, and that is one of our significant events and updates. We are actively pursuing a qualified candidate to replace her, get somebody working back in that position. Until then, if you have any needs or you have questions or concerns, I will be your contact until we can find your replacement. So as far as our significant events previously, we had one ACS verification visit for an upgrade from a level 2 to a level 1. That was a successful visit. Northeast Georgia Medical Center, Gainesville, congratulations to them. Went into that, so we are extremely proud to support them with this accomplishment. And we do have 2 level 3 facilities that had state designations in November of 2022, and they received provisional designations. They are actively correcting some of those deficiencies. We are looking for full designations out of that hopefully soon. And upcoming, we do have quite a few upcoming events. So for those that don't know, we have 2 new level 1s scheduled for, or not new, I'm sorry, but we have re-verification visits coming up in April. We're excited to be a part of those. We will be present with you. I know ACS leads those, but we're going to be there just for support. We do have another level 1 facility. Their date has since been confirmed with their ACS verification visit being in June. And we have 3 level 2s with confirmed dates that they are going to be verified in May, June, and July. We have 4 level 3s that are awaiting confirmation right now. for their ACS consultation visits. Those are slated to happen in September. And we also have 5 level 4s that are due for redesignation. We are currently kind of walking through what that process is going to look like before we just show back up for redesignation. We want to make sure that those programs are successful and have all the resources and all the knowledge that they need prior to us coming back for that redesignation visit. But we're extremely hopeful for their success and ours as well. We do have 9 potential new level 4 centers coming on board. Those are going to be in EMS regions 2, 3, 4, 7, 8, and 9. So that's encouraging, especially looking at the map that we saw earlier and some of the lack of the southern regions. And we do have ESO and Industry is preparing the 2023 schema for users to install, enabling users to continue to import their 2023 records. Marie Probst is working on reports in the patient registry that'll be similar to the reports that come out in the V5, and the 2021 data export for epidemiology, time to definitive care analysis, and using biospatial. And I'm going to let Marie actually give y'all a little bit more information and successes with our registry data.
Thank you, April. Hello, everyone. I'm Marie Probst. This is just a reminder, we do have some data in the biospatial site, June 2017 through June of 2021. And as soon as we're able to do the export from the patient registry, we will have the remainder of the 2021 data in the biospatial site, and then we'll hand that off also to the trauma epidemiologist so she can begin preparing her 2021 annual report. And well, today is actually the due date for the download to the patient registry for the 4th quarter calendar year data for the trauma registry data. And so once that closes out, then we'll give spatial and our trauma epidemiologists the 2022 data.
I think she's telling all y'all to log in right now. You're in one.
And the GQuip set. Yes, 3 downloads. We aligned the download date for the Office of EMS and Trauma's patient registry download to be in line with GQuip and TQuip and NTPB. So it's easier for the centers to remember the due date for the download. The other thing I want to mention is the 2020 annual report for the trauma registry data is available. We've already distributed it, but that was distributed in January since your last meeting. That's why it's here. And we are receiving the 2022 downloads, and we have the 2021 data. And as Gina mentioned earlier, that and Dr. Dunn also mentioned, we are missing data from 2 facilities for the 2021 data, but we are moving forward with exporting the data without those 2 centers facilities. That's all.
And I want to touch a little bit on the patient registry. So for those that are patient registry users, and for those that are potentially looking to join the patient registry, we did finalize a report writer seminar. Our image trend liaison is going to be coming here. We're going to offer 2 public sessions for this report writer training. It will be a full day class. I've been assured that this training will not just help us generate a basic report, but very robust reports. She said that each user should be very confident with using these reports by the time this training is over. If you want to mark your calendars, the dates are going to be April 25th. There will be a session at Houston Healthcare in Warner Robins. And then the 26th, there will be at Northeast Georgia, Gainesville. So
hopefully far enough apart, but close enough to your centers that, you know, it shouldn't be too far of a commute. And again, this is for current users or anyone that could be interested in seeing what the functionality of the patient registry is. A save the date and a calendar invite will be officially sent out later. So I just confirmed all of those dates yesterday.
Hey, good morning. How are you? Just wanted to give you an update on the armband project. As you remember, this is the governor's office of public safety helped fund this project. Our ultimate goal is to link crash records with EMS records with trauma registry records, so that we have a big picture of everything about this patient. We have completed training for our EMS and our law enforcement partners in the pilot area. We meet with the hospital systems in the next 15 hospital system, which has 2 hospitals that are going to be part of this pilot. We meet with them in the next 15 days to finalize the hospital's part of the participation. And we already have an identified place in the patient registry, Dr. Duncan. Great. That the number will go. What we're trying to finalize with the hospital system is where it's going to go in the patient's record, so that the trauma registrar has access to the number to get it into patient registry. And what this project is going to do is help us deterministically link the crash record with the EMS record in both EMS records if the patient is transferred. So for those of you who are having problems, you're getting a patient transferred in and maybe it's the second transport, but unable to get the information from the first transport. We're hoping this project will help us link those records as well, so that we can get the time to care metrics for those patients that receive more than one EMS transport, as well as link it with the crash record. We're going to start out as a pilot in just 2 counties, so we can get the kinks worked out, make sure we've thought of everything. And then once we get that finalized and it's working appropriately, then we expand it out to the whole region on a bigger scale. And then once we make sure that's working appropriately, expand it out to the rest of the state. But we're closer today than we were 6 months ago. Kind of excited about that, but like I said, the last part of this was the hospital system. We meet with them in the next 14, 15 days to finalize that project, to then get this going and on the ground.
Sounds great, Kelly. How long is the pilot project?
We're estimating about 6 months, but we're saying estimate because we want to make sure we thought of everything. And we've got all our I's dotted and our T's crossed before we roll it out. Because like any of you in your systems, when you roll something out wrong the first time, then when you go back and correct it, it's hard to fix what you've already been told. So we're hoping 6 months, but we'll know better once it gets started to make sure we captured or we thought of everything. Because like I said, we're trying to pull in the crash records as well as we think I think the most difficult part is going to be patient going from hospital number 1 to hospital number 2. Making sure the armband doesn't get cut off, making sure everybody gets that number. And then, like I said, we've already got identified in the crash record, the EMS record, and the trauma registry record where the number will go so that we can get them all linked. But it's getting it in the patient's medical record first so that the trauma registrar has access to get it into the registry.
I think that's great. Obviously, they could solve a lot of our problems and get that going. Sort of the holy grail for being able to link the crash data and get the evidence,
Get a bigger picture.
Yes, that'd be awesome.
Yeah, and I know it's been a little bit frustrating of how long it's taken, but I also think that it's such a big project, we want to do it right the first time. So we don't have to re-correct or re-educate on something we didn't think of.
What region are we in?
The region 2, White County and Logan County. Okay. It is the first 2 counties. Like I said, it's 4 EMS agencies, 6 to 8 law enforcement agencies, and
and 2 hospitals.
That's great. We look forward to the results. Anything else?
Any questions for us?
Okay, well, I haven't got to meet you yet, April, but I've heard great things. Welcome aboard, and look forward to working with you. And for those who may not know, there's a lot of work going on between our data groups, between the commission and OMS&T, and I'd just like to acknowledge them. They're really working. I think you're going to, over the next year, you're going to see some spectacular things between the two groups and the registry data and things. So just stay tuned. It's going to be good.
Thank you.
April's been a quick study. She's been a very quick study. She's spent a day in Madison, and now she's got the low down.
Dr. Ashley, she's also going to be one of our state representatives and attend our survey.
Oh, okay. Very good. Very good.
And I mean, like I said, I know ACS runs the show for those visits, so we want to be a part of them. We want to be, you know, a presence and a support for, you know, not just y'all's facility, but for every facility, and stay, you know, as involved and active with everyone as we can.
Very good.
Right.
Thank you.
Thank you.
Okay, that concludes all the report outs. As far as new business, I'll open up with everything that didn't make the agenda. Going forward, we don't know about late breaking news. Okay, I have none.
Can I just, I want to make one,
known.
you should have known.
I should have known.
I just wanted to introduce, because he actually, today is day 1 of his contract. I don't even think he's improved in the vendor system yet, but he's so aggressive. He's actually here for the meeting. Greg Nickel, who's in your region, who's our stop and bleed coordinator, working alongside Crystal Smith, who, if you don't know, Crystal, Benji Christie, our state COT chair, Crystal's the Georgia champion now for stop and bleed. So Greg will work to support her in all the work so that, you know, Crystal and her 3 full-time jobs can have a little help with all that work. So Greg, thanks. We look forward to you know, getting acquainted with you and really putting, you know, getting, now that we have our new process for stop and bleed kits, so we can do some more distribution. Thanks.
Welcome aboard. Any other updates? Can I get a motion to adjourn?
So moved.
All those in favor, aye?
Aye.
Aye. Thank you. Stand adjourned.